Welcome. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology. This is TB testing in the 21st century, and this installment is by my good friend Jack Cush. I've challenged Jack to give you an overview of TB testing in the last century. I want him to discuss the nuances and the technical aspects of both old school and new world TB testing. Jack is the Director of Clinical Rheumatology at the Baylor Research Institute in Dallas. Welcome, Jack.
Thank you, Len. Hi, my name is Jack Cush. I'm here today to talk about TB testing and specifically the history of TB testing and its current use in treating patients with rheumatic diseases. So we're going to talk today about both the identification of latent and active infection. Latent infection would be defined as someone who has a positive test for TB, and we'll get into what those are in a minute. But that would also include patients who have no signs and symptoms and a negative chest X-ray. The identification of latent TB infection indicates a dormant infection, but the identification of such latency or sensitivity to the tuberculosis bug indicates that there is a significant but small risk going forward of developing active TB. It's important to recognize that there are risk factors for developing latent TB, and these are shown on the right. That include close contacts, those who are homeless, IV drug abusers, being foreign born, especially coming from endemic countries, and those who are imprisoned. But then the progression from LTBI or latent TB to active infection can be seen in other high-risk groups. Those who are immunosuppressed, such as the HIV population, those who have close contacts, and others are listed here, and including patients who have received biologics, especially the TNF inhibitors. So it's important to screen patients who are going to go on biologics and patients who are at risk for latent TB infections. Most important would be to identify a high-risk person, such as someone who has had a household contact or recent contact, those who come from or reside in high-risk areas, and there are other numerous risk factors as previously mentioned. The package insert for the use of TNF inhibitors and other biologics suggests that patients should be evaluated for TB risk factors and tested for LTBI prior to and periodically during therapy. So that last part we'll talk about later in the talk, where we have to assess the need for ongoing testing. So we can test in many ways, including the tuberculin skin test, which is the historic test, but newer assays such as the interferon-gamma releasing assays, heretofore referred to as IGRAs. Also, chest X-rays can be used, but these are non-specific as they are most useful in the identification of active TB and the identification of granulomas, fibrosis, pleural thickening. Again, these tend to be features of active disease more so than patients who have latent infection. So the history of TB certainly is a long and storied one. It'd be nice to diagnose TB by culture techniques and or by serologic techniques. However, these have their limitations. The TB skin test has actually been around for over 100 years when in 1882, Robert Koch, famous for Koch's postulates, first discovered the tubercle bacilli and its relationship to tuberculosis. In fact, Koch himself in 1890 was using the broth of cultures as a means of identifying a reaction to the tuberculosis bug by injecting this into animals and seeing extreme hypersensitivity. Early on, he postulated this may be a form of therapy that could be used, but that proved to be incorrect. In 1907, von Pirquet actually applied this tuberculin, or what was called old tuberculin, as a test in the diagnosis of tuberculosis. So this has really been a formal test for almost 100 years, since 1907. In 1941, Charles Mantoux refined the test and set up many of the procedures we currently use to test for TB using the partially purified derivative as an intradermal test administered via syringe. So the tuberculin skin test basically assesses cell-mediated immunity in the form of a delayed type hypersensitivity reaction to this intradermally administered purified protein derivative, or PPD. What we use now is called PPDS, but it should be realized that patients who undergo this test may not always be positive, especially the immunosuppressed where sensitization may be absent because of allergy. The PPD itself is a poorly specific and crude mixture of over 200 mycobacterial proteins that are certainly shared by the MTB, M. bovis, and the BCG substrains. But it also can be seen in a few of the atypical or non-tuberculous mycobacterial species. To administer this test, 0.1 mLs of an intermediate strength, 5 TU strength of PPD tuberculin must be intradermally injected, usually into the volar surface of the lower forearm using a 27 gauge needle. It's important that this be administered intradermally and that you produce a wheal of up to 6 to 10 millimeters in size to have a proper result. The results should be measured 48 to 72 hours later, where one is looking for an induration, not just erythema, but induration that is greater than a certain number according to your risk factors, and we'll get into that in a minute. But TST reactions, it should be noted that they can be positive for up to a week. It's also important to note that negative reactions are only accurate for the first 72 hours. So it's important to measure induration and not erythema in its transverse diameter using a measure as shown here. It should be done by trained healthcare professionals who will both administer a test, measure it, and interpret it. And it's best done when it's done by the same person. The reaction should be recorded in millimeters and not as a positive or a negative. What is positive or negative depends on your particular population or the patient's population. So for instance, recent CDC guidelines have changed the targeted numbers to have what we call targeted testing, meaning high-risk individuals have a lower degree of positivity. So 5 millimeters and above is said to be positive if there's induration on the skin. And again, this would apply to certain populations, the HIV population, close contacts in a TB case, persons who have a chest x-ray that's consistent with prior untreated TB, those who are immunosuppressed, and organ transplant recipients. Greater leeway is allowed for other populations such as recent immigrants, IV drug abusers, residents or employees of congregate settings, prisoners and whatnot, lab personnel who are working with mycobacteria, persons in clinical conditions that puts them at high risk, and then children under the age of 4 also may be in this category where 10 millimeters and above would be interpreted as positive. Those who are very low risk, a 15 millimeter threshold is used as a positive result. And this would include someone like a librarian who's not exposed to anyone with TB or not dealing with any of the medicines or conditions we've talked about thus far. Now, you can certainly have false positive TST reactions. This commonly occurs in patients with a few strains of the non-tuberculous mycobacteria, but usually such reactions are barely positive and certainly less than 10 millimeters. Patients who receive BCG vaccination will become TST positive. However, this wanes over time such that more than 80% of patients should be PPD negative as adults. The TST is usually due to TB infections in patients. TSTs may be positive, however, in these patients. Anergy certainly can give you a false positive TST reaction, but anergy testing is no longer recommended because of the inaccuracies of anergy testing. Recent TB infection, early on, they may be negative. The very young and newborns may be negative. Those who have recently received a live virus vaccination, which may temporarily suppress the TST reaction, overwhelming TB disease, and then those who have had a poorly administered test. So the algorithm for someone who, for instance, may be at high risk, someone with rheumatoid arthritis or psoriasis who's about to go on a biologic, we're going to use a 5 millimeter cut point as being positive. The patient should be evaluated with a careful history and physical examination, looking for signs and symptoms of active infection. The tuberculin skin test should be administered, and if negative, you can see on the right that person could then go on to receive the biologic therapy. However, if the tests were positive at 5 millimeters or more, the patient should undergo chest x-ray evaluation. On the left, you can see that if they have a positive test, they're said to have active TB and they need to be treated for active TB. And then once they're treated, then they could undergo treatment with the biologic. Those who have a negative chest x-ray can initiate their biologic therapy as needed. Regardless of whichever arm that you go in this pathway, the patient who is receiving a biologic needs to be continually monitored for symptoms and signs of active mycobacterial infection. So the strengths of PPDs are well known. It's historic, it's been around for 100 years, it's fairly cost effective, and it's been studied in many populations. Limitations are numerous. There are the problems of false positives, especially in patients who have been vaccinated with BCG and in certain non-tuberculous mycobacterial infections. When the PPD is either not administered correctly or not read correctly, this can certainly yield false positive results. There are certainly inaccuracies in how the test is placed. The measurement of induration is often a large debate. It's not uncommon in healthcare situations to see a nurse, the doctor, and several personnel arguing about whether this is 5 millimeters or 6 millimeters or less. Overall, the test has low predictive value, and it seems that there's been a loss of TST specificity as the prevalence of TB has declined in recent years. The important thing would be that to demonstrate that TB testing is in fact worthwhile, and here's two examples of that. On the top half of this picture in white, you see a graph of the adalimumab drug development experience. On the far left is the frequency of developing TB in an era when they did not require TB testing when you were receiving the TNF inhibitor adalimumab. And you can see there's a fairly low incidence, but a sizable incidence of 1.3 per 100 patient years of drug exposure. After that period, which is felt to be more than a high and unacceptable rate of positivity and developing TB, they administered the policy of testing. And you can see in 3 different ways that reduction in actual TB events was sizable, in fact, almost 85%. On the bottom in blue is the experience from the Spanish biologics database, the BioBedasser database, that looked at almost 3,000 RA patients who were treated with 7,800 patient years of drug exposure. Prior to guidelines which required the use of tuberculin skin testing, they had a TB rate of 52 per 100,000 patient years. After the guidelines, this dropped significantly to 117, with essentially a 78% reduction in all cases. When they looked at only the RA patients, there was an 83% reduction in the frequency of TB just because of the administration of the TST and identifying patients at risk and treating them for LTBI prior to commencing therapy with the TNF inhibitor. The package insert, as stated earlier, that patients who are tested for latent tuberculosis infection should have periodic testing. So again, it specifically says that LTBI should be tested before initiating and during TNF inhibitor therapy. Now, what that means is really not been stated. There are certain societies that say that this should be done annually no matter what. The evidence of this comes from several sources. Galicia, one of my fellows, actually presented this data in 2006, where in our 300 plus patients, first time user of a TNF inhibitor, 3.1% of the population was TST positive. On patients who were negative and went on to receive annual testing, the first go-around of 108 patients who had their TB tested, their TST tested in year 2, we found an additional 6.5% of patients who were essentially new conversions. It's unclear whether that is from anergy that was corrected by correction of inflammation or that was new infection. Fuchs et al. Looked at 40 Israeli patients and also showed a significantly high rate of initial TST positivities. But on second test, 3 months later, an additional 20% of patients were new converters with an increase in their TST to greater than 6 millimeters over their baseline. Essentially, it's a 2-step test showing new conversions. Park looked at 86 Korean patients, of whom they identified conversions in 28 with a 32% conversion rate. So some of these, again, could be because of the correction of anergy, some could be because of active infection. In this study from the LA County Hospital, Corey and colleagues looked at 411 patients, had TST testing in 382, and on the right you can see 100 of them had evidence of LTBI and went on to receive treatment with INH for 9 months. Of the remaining 282, you can see that 149 and then 74 and then 11 patients had annual testing done at year 1, year 2, and year 3, and that a subset of those individuals, in total 30 patients out of the 282, were found to have subsequent positivity. So essentially about 10% of patients will convert over time, calling for the need for repeated testing. When they looked at their 30 patients, 7 of them were culture positive, indicative of essentially new conversions from active infection. The remaining patients could be said to have anergy-associated TST negativity that was corrected by correction of anergy. So it's important that if you do identify on repeat testing a new positive, that you also do culture testing. Another way of looking at the problem in screening patients is with a newer assay, the IGRAs, the interferon-gamma releasing assays. The FDA has approved several of these tests as indirect measures of MTB infection and should be used in a conjunction with other risk assessments, imaging, and other typps of medical evaluations. There are 2 assays currently on the market. The ELISpot, more commonly known now as the T-spot TB test, was developed in the late 1900s. This is an ex vivo ELISA assay that measures the number of antigen-specific T cells that produce interferon-gamma through a spot assay. The quantiferon assay, the more recent version called the quantiferon gold in-tube assay, also measures responsiveness to TB antigens, but in this case it measures just via ELISA, looking at the supernatants taken from cells in culture. So there are several generations of quantiferon, initially approved in 2001. The second generation added ESAT6 and CFP10 as other TB-specific proteins, and then the third generation added TB7.7. All of these are antigens that are specific to MTB and are not found in the BCG substrains. So this is a cartoon showing you the potential test that could be done. On the left is the methodology used in tuberculin skin testing, looking basically for a DTH type response at 48 to 72 hours later. On the right is what happens after you draw a sample of blood. This can be cultured and done as a TB spot test or as an ELISA or the quantiferon test on the right. Here you can look at the test that will give you a positive IGRA. Certainly it is seen with MTB, but a few non-tuberculous species such as Kansasii, Solgai, Marinum, flavescens, and Gastri, these could also produce positive IGRAs. When looking at the sensitivity and specificity, this particular report looked at a combination of reports and gives you basically an overall view of the relative sensitivity. On the left, the IGRA sensitivities look at the quantiferon gold, the quantiferon in-tube assay, and the TB spot test on the bottom, with the far right line being the 100% mark. And you can see most of these are around 90% sensitivity. The middle panel looks at IGRA specificity, all showing a very high specificity. And on the far right, you look at the sensitivity of the TST test, which seems to be about the same, but maybe a little bit less than the IGRAs overall, but still has a very high specificity like the IGRAs. However, on the bottom right panel, you can see what happens to TST testing when you look at those who've been vaccinated with BCG. The specificity drops significantly, which is why you might want to use an IGRA in that situation. This shows you the comparative value of either the T-spot TB test or the quantiferon in-tube test, and basically see in these 69 Italian patients who are about to start on a TNF inhibitor that they perform essentially the same in this population, identifying the at-risk population. So again, a TST was positive in 26%, the T-spot TB test in 30%, and the quantiferon assay in 32%. The kappa, or the agreement statistic, was 0.21, which is about the number you see in many studies, although it sometimes goes as high as 0.9. But here's an overall look at 11 different studies that looked at the agreement between tuberculin skin testing and IGRAs. You can see that the kappa statistic, as highlighted in the middle, ranges from 0.14 to as high as 0.6, with most of them centering around 0.3. So the performance of this test seems to be well known. It has greater specificity than the TST because it lacks the influence that can be seen by BCG vaccination. Patients who are active culture positive TB infections, the IGRA sensitivity is certainly up to 90%, and that either is equal to or somewhat better than the tuberculin skin test. In low-risk populations, you may not need to use this test, but if you do use it, it certainly has a very high sensitivity. Its correlations with TST may be lower in the immunocompromised. It should be noted that IGRAs are not capable of distinguishing between active and latent infection. So the predictive value, it's important to note that these tests, if you do them, actually has some predictive value. It is generally believed that if you are TST positive, one's lifetime risk for developing active TB is between 5 and 10%, and possibly increased by the size of the reaction. So the larger reaction, the greater the risk. There are recent studies that are looking at the comparative value of IGRAs, and they may in fact be superior. In a German study of 601 close contacts, you can see that looking at TSTs, 2.3%, only 2.3% of those who were positive by TST developed TB, whereas those who were quantiferon positive, 14.6% developed TB positivity. The same was seen in another population of 807 HIV positive populations, where 44% were quantiferon positive and 793 were quantiferon negative. It is this 44 who actually had the quantiferon test positive who had TB at entry, 7 of the 44, and it's that population who was quantiferon positive who actually showed patients to go on to develop TB as they were followed over a 2-year period. So again, there is some evidence that doing the quantiferon test may have some greater value than the TST, but there's some that says that it's actually equal to the TST in predicting those who develop TB, which is shown in the last bullet amongst 339 immigrant workers. So comparing these tests, one's in vitro, one's in vivo. Certainly the TST is less specific than, but there may be more specificity with the IGRAs that use specific antigens. Boosting phenomenon is certainly possible with repeated TST administrations. Boosting has not been demonstrated in the IGRA assays. IGRAs have the advantage of doing one test at one time through phlebotomy. TST requires multiple visits and expert assessments. It requires 2-3 days of assessment, whereas the IGRA results can be printed out and reported in 24 hours. There are less issues of inter-reader variability with IGRAs, but there are issues of lab variability. The IGRAs can be drawn, stored, and tested later if need be. And then bottom line is that the IGRAs do cost more compared to the TSTs. This is one algorithm one might consider in looking at IGRAs and TST testing in the population. If you do both and both are positive on the far left, you have evidence of LTBI and the need for treatment. However, if one is positive, which is the 2 middle boxes, TST positive, IGRA negative, you could observe the patient. However, if there is strong evidence of TB infection, a TST reaction of 25 millimeters, for instance, or a very abnormal chest X-ray, that in itself might be strong evidence for positive LTBI and the need for treatment. If you are TST negative and IGRA positive, this author suggested that you might want to repeat it in 3 months, and if it is positive, again, still, then it is evidence of LTBI. If it's negative, then you might not need to treat it. This is what happens when you apply this test to a low-risk population. In a high-risk population, patients on immunosuppressives or biologics, either TST or IGRA positivity is a strong indication for the need for treatment for LTBI. Obviously, if you are TST and IGRA negative, you do not need to be treated. The CDC has updated its recommendations in 2010. They are useful aids in diagnosing MTB. They may be used as surveillance tools to identify persons who may benefit from treatment. Both the TST and IGRA should not be used to test patients at low risk. Either can be used to screen either recent contacts or periodic screening of healthcare workers. It is said that the IGRA may be used in place of the TST, but not in addition to the TST, although there's some debate about that. IGRAs are preferred in patients who have been previously vaccinated with BCG or patients who are unlikely to be no-shows on return visits. The TST is preferred in children under the age of 5. Nonetheless, there are many countries, including Germany, Switzerland, and NICE in the UK, who favor a dual-step strategy to screen patients first with a TST and then use an IGRA as secondary confirmation of TST-positive individuals. Overall, in this meta-analysis that looked at the utility of these tests, they suggested there's strong evidence favoring IGRAs in screening high-risk groups, healthcare workers, immigrants, close contacts, those going on immunosuppressants. Last year, we published in the Drug Safety Quarterly a publication in the American College of Rheumatology guidelines that's taken from many different sources. This comes from Kevin Winthrop and myself. Number one, everyone should be screened for LTBI prior to using a TNF inhibitor. That could include either a PPD or IGRA. Second, IGRAs are indicated when available and certainly when there's a history of BCG use. Third, BCG vaccinated individuals should be tested for LTBI. A positive test is more likely to indicate infection rather than PPD positivity related to the test. 4, PPD or IGRA positivity is evidence of active infection and needs to be treated. 5, two-step TSTs are only recommended for healthcare workers at the time of hire. 6, a chest X-ray is only helpful in diagnosing active TB, not so much for screening. 7, PPD testing should be repeated and done periodically, especially when the patient's risk warrants that, if there's new risk, a change in risk, new exposure or contact. 8, documented history of adequate treatment with LTBI or active infection can safely allow the patient to receive a biologic or TNF inhibitor in the future. However, future risk of conversion and or reactivation is proportionate to the ongoing risk or exposure risk that person encounters. And lastly, LTBI, in how you time your LTBI and treatment, the package inserts for many of the drugs say that preventative anti-tuberculosis therapy must be initiated before giving a TNF inhibitor or a biologic. That means it should be given right before. There's no need to wait a month, 2 months, 6 months. Lastly, there are no guidelines that recommend TST testing for methotrexate and other DMARDs. Thank you very much.